All right. Hello, everyone. Thank you so much for joining us today. We are very excited to be here. My name is 𝐓𝐰𝐳𝐤, and I'm the Executive Director of Children's Craniofacial Association. And this is our June presentation in our virtual program series. So I'm very excited to be here today with Dr. Labow. He is going to be presenting in honor of Apert Syndrome Awareness Month on Apert Hand and Feet surgery. And I'm sure there's some other great information in there as well. But I would like to introduce Dr. Labow and just again thank him for his time. He's the Associate Plastic Surgeon in Chief, the Director of the Adolescent Breast Clinic, and an Associate Professor of Surgery at Harvard Medical School. And he is a member of the Boston Children's Hospital craniofacial team. And so this is going to be a wonderful presentation. And just before I turn it over, I'm just going to read a quick disclaimer. As everyone knows, we always do this in our sessions, but I'd like to tell everyone and remind them that this session is for informational and educational purposes. It is not intended to diagnose or treat any illness or condition. No one on this webinar can offer specific or individualized medical advice, but they can share from their own experience. For medical advice and professional assistance, we suggest you contact your personal medical doctor or craniofacial team. And please understand that the views, thoughts, and opinions expressed in this webinar belong solely to the speakers and not necessarily to the Children's Craniofacial Association, the speaker's schools, employers, organizations, committees, or other groups. So, Dr. Labow, I'm going to hand it over to you and let you take it from here.
Terrific. Well, thank you so much for that wonderful introduction. And it is an absolute pleasure to be here and to speak about a subject that is very sort of near and dear to my heart. So thank you so much. Let's see, it seems to be working pretty well. So let's see if I can get my talk up here. Great. Is that visible now? So first off, I should say that although my name is on the title slide, I always am working with a great team here at Children's, and in particular, my dear friend and partner, 𝐓𝐰𝐢𝐭𝐚𝐸, who both he and I were trained by Joe Upton, who really is one of the sort of the founding, thought leaders in terms of Apert hand management. And so we sort of come from that school, and we've been able to sort of take what he's taught us 20 years ago and then bring it into our own practice. And so I just wanted to shout out to those two other hand surgeons who are just absolutely part of this talk as much as I am. So we'll talk a little bit what is an Apert hand? What are we talking about here? Some people obviously know through their own experience, and other people have only seen their child and may not have a broader understanding of what's common and what's unique. We'll talk about what at Children's, what our sort of broad treatment philosophies are, and sort of the rationale, like why do you do what you do? Like what's the basis for it? We'll talk a little bit about the syndactyly release and sort of how we do it. But we'll also talk about some refinements and things that beyond that sort of early 2-3 years of life, what else is out there in terms of addressing some of the surgical issues with the hands. And we even have some long-term outcome data looking at like 30 and 40-year-olds with Apert syndrome, what their hands are like and what their life is like, and share a little bit of that information with you. So that's basically the preview. So what's an Apert hand? So all Apert hands have the following features in common. There is some degree of complex syndactyly. The fingers on both hands and both feet are joined, and they're joined at the bony level as well as the skin level. Sometimes the border digits, the thumb and the small fingers, are a little less involved, but these are not just skin only, partial syndactylies. This big word, 𝐓𝐰𝐢𝐭𝐚𝐸, basically means that the joints within the fingers, so the PIP and the DIP joints, do not work, meaning they don't bend. Now, there are some exceptions, and the occasional you'll have a little motion in the small finger, but for the most part, the joints in the fingers don't bend. The thumbs usually are short and they're radially deviated. They bend away from the hand as well. And again, unlike other craniofacial conditions, in Apert syndrome, the hands and the feet are always an issue 100% of the time. So it's really an important subject for patients and parents and family members to address. So Generally speaking, we broadly categorize the Apert hand into one of three types. Although, of course, every hand is a little bit unique, and so there can be variants within these. But generally speaking, the type 1 hand has a thumb that is completely free and fingers that tend to be in a single plane. So they're relatively easy to address in terms of separation. The type 2 hand, the thumb is connected, but usually just with soft tissue. And there's a little bit of palmar convexity, meaning the fingers kind of roll in a little bit. But in the type 3, the thumb is really pulled in. It can be difficult to really discern where the digits are. And you have a very, very, very deep and concave palmar surface. And those are really the three basic types. And if you look at the x-rays of them, you can see that as you proceed from type 1 to type 2 to type 3, they're increasing levels of complexity in terms of what bones are going where and what bones are fused with what bones. So what are our broad thoughts on treatment? So obviously, and maybe not obviously, our goals are really to optimize function. We want to make sure that we put the child in the best position to use their hands most effectively. And what can be amazing is even before surgery, the child figures out a way to use their hands regardless of type. And even those type 3 hands can work really well to do things. Our job is to try to make that easier and try to improve that. There's not usually a lot of therapy required. Most of the ability rests within the child and within the child's hands. We're kind of just unlocking it and trying to augment what's already there. Not too far behind. We want the hands to look good. We think it's an important part of it. We want to really try to get the best appearance that we possibly can. And there are lots of things we can do that are very simple to really help improve just social functioning and confidence about the appearance of one's hands when one goes to shake hands, give a high five, give a fist bump, those sorts of things. You put your hand forward in all of those instances. And so we want to try to make the appearance as good as we possibly can as well. We really rarely have to amputate a digit. Okay, that's a very, very unusual circumstance. And so that's one of the early questions that comes up. And we still see people from all over the country and all over the world, frankly, where the advice was to amputate. And so we try to avoid doing that routinely, frankly, because we just don't have to. It's just not necessary. And again, there's no single pathway. We will work with the parent and we will work with a child as they get older to address their concerns and to find the safest and the most predictable way to achieve the goals that are necessary. So it's not like everyone gets the exact same number of stages or the same number of steps or has to do this. There's a lot of variation from person to person and family to family based on a large number of factors, from where the patient lives. Does the child or the parent want to have more than one cast at a time? What is there? Do they have other ongoing Apert concerns that are driving treatment? All those things need to be considered in terms of getting a treatment plan in place. And then probably where we deviate a little bit from other centers is we don't stop at separation, meaning we don't stop at age 3 and go, oh, you got 5 fingers, we'll see you later. We really do view this the way, cleft care or craniofacial care is, that we really want to follow the child through to skeletal maturity, not necessarily doing surgery every year, but keeping an eye during growth spurts, particularly during early adolescence, or later on when there are a lot of nice things we can do that are pretty simple that can maybe build upon our earlier work. So it's not just 3 years of sort of surgeries every 3 months or 4 months. It's a longer term view. As I mentioned, we work in 2 surgeon teams. So we try to really radically cut down the anesthesia time for patients. And I think that really speeds up recovery. So we have patients, we don't rush, but we are efficient, and we can typically get 4 extremities done by early to mid-afternoon, and patients are often good to go home the next day, believe it or not. So we've really cut down on anesthesia time, and that's really helped quite a bit. If the patient wants feet done or the parents want feet done, we'll do the feet. You don't, we don't have to. So we will work with you to figure out what the right thing to do is. And we have a great anesthesia team as well. You want to have an experienced anesthesia team to help with anesthesia, IV lines, blood pressure monitoring, and then, working out some of the other social challenges with a 4 extremity operation, if that's the way we go. So that's generally speaking kind of how we do. And I'll talk a little bit more about post-operative care once we start looking at some of the specific operations. So are 5 digits possible? Yes, nearly always 5 digits are possible. And that's often one of the very first questions that we get right after, amputation is, well, are there fingers in there? Can we get 5 fingers? And really, if the bones are there, we're going to get 5 fingers. That's not very, very unusual to not have that be the case. Now, depending upon the circumstances, we may be able to do that in 2 stages. It may be better for us to use 3, and I'll explain why as we get a little bit further on in the talk. But we don't sort of draw a line in the sand and say it's only going to require 2 or it's only going to require 3. Some hands, it's very easy to do it in 2 stages, but there are some where it's possible to do it in 2, but you're going to get a better result and a more reliable result if we end up staging it using some techniques to make subsequent procedures easier. So it's not always about the number of operations, but more about putting ourselves in the best position for the best functional and best looking hand. And then we have a host of additional techniques that I'll talk about later on in the talk that will help us to achieve that 5-digit goal. So approximate treatment model, again, we're going to do hands are going to be our focus in the first, just separating things the first 2 to 3 years of life. Age 5 to 10 is where we start focusing as we get into school age about the thumb and making it a little bit straighter if it needs to be. And straightening digits, is there a finger bent? Is there a finger curved? What can we do to just make sure the fingers are as aligned as possible? And then we do additional straightening, aligning as we get into the teen years. And then finally addressing things like scars, nail deformities, other things later on in life, if they're an issue. So we sort of stage things, and this is sort of generally speaking what we're looking at. So this would be an example. I would say this would be a type 1 to type 2 hand. And yes, you can see the palm, you can accurately localize, where you're going to make your incisions. And so you can separate the 2 fingers, the index and the small finger, and then do the next one at the second stage and have 4 fingers in 2 stages. And this is generally what we use. We use these triangular flaps on both the palm and the dorsum, and then we lift those up and we use those to sort of reline or recontour the commissure, and then use skin grafts for the sides of the digits. So this is what a flap elevation looks like. This is in the first case. So we lift that up and we sort of meticulously dissect out these little structures. We preserve arteries and the nerves, and the tendons get split and the bones get split. We divide the nail. In some cases, we make the nail plate a little narrower. So lots of little things happen during the separation, not just, separating them. There's a lot of dissection that goes on using, loop magnification on our glasses. And you can see here, this is just a nerve that we will then dissect and split between the 2 fingers as we go, as we dissect. So it's pretty small structures that are being separated. And once the separation has occurred, we will take skin from the lower abdomen and use that to line the sides of the digit. Now, there's a lot of talk about donor site and groin and arm and other places. The lower abdomen is a beautiful donor site. It provides very good skin quality. It's typically not super hairy, and the donor site should look like this when you are done. This is a child who has had 2 stages, so 2 separate harvests of that skin, and that's the result. So it should be as good as a tummy tuck. It should be that nice, so we really take a lot of pride in making sure that our donor site closures look as good as the actual surgical site. No big track marks, not a lot of wide scarring. We really want to close the abdomen nicely. And so this is what it looks like. We sew the grafts on with dissolving stitches, and then we put casts on. So once the child wakes up, they've got the cast. They can move and crawl and bang their hands against the side of whatever they want to, and the wounds are protected. There are no dressing changes, except at 3 weeks, the casts come off, they go right into the tub, and they heal well. And that is, again, a big difference in terms of how we manage it, but it's much easier on the patient. It's much easier on the parent. And frankly, our healing is great so that we don't have a lot of shear or problems with our graft taking. And so our scar quality is excellent as well. So that is a bit of a philosophy difference than a lot of centers, but it works very nicely for everyone. So this is what example, this is after the first release of that patient. Then we go back and we do the middle 2 digits. And here we have 4 really nice fingers after 2 stages. Great, that works well for that hand. But there are some hands that are a little more complicated. And it's going to be really, really, really hard for me to draw those palmar triangles for that 3rd web space accurately here. So we take a bit of a different approach with the type 3 hand most of the time. And by that, I mean, we will release the thumb and the small finger first and use that first operation to reposition or straighten the central 3 digits. And that's going to make the second and then the 3rd operation much easier and safer to do, rather than just try to force a bad position and do the 1st and 3rd. So do this and then do this in 2 stages. It sometimes can be done, but more often than not for a hand like this, we're going to do it 3 stages. So we release thumb and pinky, and then we'll do index and the middle coalition, and then we'll do this, and then maybe do a little work to re-deepen the first. So it'll be 3 stages. So this is what it would look like. We'll prioritize the border digits. And then you can see, I'll show a better example of this later on, but instead of those fingers being curved over in the middle, they're now flat. And so we can then come back and easily separate the index, the middle, and the ring. And so we'd end up with something like this from 9 months to 2.5 years, where we've got pretty good digits after that time period. And again, it's not something that's difficult. We can achieve 5 digits, and it's really not a risky endeavor. So what is this sort of straightening procedure? It's got a name. We call it a central coalition osteotomy. And what we do at that first stage, when the pinky and the thumb get taken away, is we'll partially release the bones and then move them into position. And this is what the general cartoon looks like. We've got the ring, middle, and index finger all as one big blob of bone. We'll partially release it and then flatten it and place a wire across it. So it looks something like this. We'll make a small incision where that little red line is. We'll peel the skin down a little bit, and then where those dotted red lines are, we'll run a small, tiny, tiny little osteotome or chisel and separate those bones, allowing us to reposition the digits after the thumb and the small finger have been separated. And so you end up with a uniplanar hand rather than having the digits folded over. And so this is just a close-up here. And this is what it looks like after 1 stage. Much, much easier to address. So what happens if there's just not enough bone in the fingers? Like, you look at those fingers and you're like, oof, I'm not sure we can get a whole fingertip out of that. Sometimes what we'll do at the first stage is slide a little piece of bone in and allow that to grow, so that when we come back 4 months later, there is enough bone. And we call that phalangeal. Phalanges are the bones in the fingers. Augmentation. We're augmenting the amount of bone. So here's an example of what that looks like. So this child has, 1, 2, 3, 4, 5 metacarpal bones. And they've got, 1, 2, 3, 4, 5 proximal phalangeal bones. But when you get up over here, we've got sort of 1 thumb, we've got a pinky, But then there's this index. Okay, but I don't really see 2 in here. It looks like we're kind of missing. Like, what do we do? So rather than just saying, well, you know what, we're going to not have a fingernail or remove one of the bones, we're going to separate the digits in 2 stages. But at the first stage, we're going to slide a little bone in here and kind of give ourselves a little bit more room to work at the second stage. So this is what we drew out, imagining what our separated digits would look like. And then what we're going to do is take a little piece of bone. We're going to take this bigger phalanx, split it in 2, and slide a bone in there to create sort of enough space for coming back and having that ring and middle finger with a nice fingernail. And so this is what it looked like after our separation. And now look at that. So we've gone from just this to this. So now we've got our index finger, and there's more than enough bone now to separate for our ring and for our middle finger, our ring and middle finger on that hand. So 5 digits, 5 fingernails. We will straighten this index finger, but the point is that we've got extra bone now to work with. Now, once the syndactyl release has occurred, once the fingers are separated, we usually have a few years off, meaning you've got 5 fingers, everyone's happy, it's amazing what the child is doing, and that's great. The child's growing. You know, there's a lot of growth that's going on from ages 2 to age 6. And so things can happen. Bones can start to deviate one way or the other. Bones can fuse that are causing fingers to start to deviate and do things that are funny. And those thumbs become really important as we start to hold a pen or hold a pencil or put our hand in a baseball glove or hold a bat. Those are things that we're going to want to try to address, maybe not at age 3, but as we get to that school age. So these are just some of the techniques, and we'll go through them one by one, and we'll talk a bit about them. So a metacarpal synostosis simply means that the bones of the metacarpals are fused. And what happens in the Apert patient more often than not is that it's the pinky and the ring finger metacarpal that fuse. And when the pinky gets pulled in at its base, you tend to get this sort of small finger that starts to wander off, sometimes at very extreme levels. People think, you know, well, it still works, it still moves, you know, why would you want to address this? Well, imagine trying to put your hand in your pocket or wear a glove if you're in a cold environment. Those are things that are really, really challenging to do with this. And also the small finger, it's not as useful being out there. It's way off in left field. And so the problem isn't with the small finger, the problem is right here. And so through a relatively simple operation, we're able to go in and separate that bone and create the space that allows that small finger to adopt a much more natural position above its metacarpal. And so this is something that we've been doing now. Again, not every patient needs it, but we've been doing it for years and have had very, very good success for those that do. And so this is what you'd end up with. So instead of a pinky going off at a 90-degree angle, it's now straight. And so not really doesn't require revisional surgery. It's usually once. The bones did refuse, that's true, but they fused in a much better alignment. So you're not going to have to do this again. Corrective osteotomies. We will straighten crooked fingers if they seem to be problematic, either for the patient functionally, my index finger is starting to get in the way of my thumb, or if the aesthetically, it's really not looking too good and it's a relatively easy thing to do. So what we can do is we can straighten and sometimes lengthen the digit. Again, through a relatively small operation in which here's a child who had a very complex syndactyly. And while we were able to separate these in a staged manner, that index finger sort of became a little curved and bent at the end. And so we had 3 relatively straight fingers and sort of a crooked index finger. It is very simple to just straighten that, put a temporary wire in place, and then 4 weeks later, the cast and the pin come out, the finger is straight. Apert patients heal bone injuries and bone work exceptionally well. They are bone makers. And so it is not a problem to get good union and to be able to do a lot of things with the child's bones that might be a little bit more risky or precarious with maybe someone who doesn't have Apert syndrome. So that's a nice plus for us when we want to get good bone healing. The thumb. So our thumbs are about 60% of our hand function. And most Apert patients do have a pretty good thumb. Many are just fine and they do not need us to do anything. But there are some thumbs that are either very short or very deviated, where we can put a little distractor device on and straighten and lengthen it, using similar principles to the mid-face distraction that some patients have done to advance the mid-face later on in life. And so this is the same principle, only it's a little tiny one that just goes on your thumb. So the operation is in 2 stages. The first, this is just an example of a short thumb. We had done other operations on it, but the thumb is still pretty short and it's a little bent. And so what we're going to do is we are going to divide the bone and we are going to then put a device on it that will allow us to stretch it and make it longer. And this is what the device looks like. This is an X-ray. And you can see here that the bone has been, this is one end of the bone, this is the other end of the bone. And we've got all this new bone regenerate here. And we'll often put a little graft in, but look at the length you've gained of that thumb. That's a much easier pinch and much easier grasp rather than having that thumb way down over here. And so that is a 2-stage operation separated by about 6 weeks or so. The parent does turn the crank daily. It doesn't usually hurt. There can be some pin site tenderness early on, but usually it's pretty well tolerated. And we can get about 1 inch or so length on that thumb, which is usually more than enough. Another nice thing is in some cases that additional bone can make the thumbnail look a little nicer. Your nail is kind of resting on the phalanx to create that, to give it its appearance. And so just having that added bone there can often give you a bit of a more stable thumb tip and a little bit more natural appearing thumb tip as well. So you do all of this, what's the end result? Up until recently, there really has been very, very, very little written about like the adult Apert hand, like when I'm 20, when I'm 30, what's the deal? What am I ending up with at the end of all of this? And it was really instructive. We sort of went around the country and talked to adult Apert patients. Some were our own patients, some were other patients, and did 2 broad types of analysis. One was to look at the patient's perspective. What's my quality of life? What's my perceived disability? And then interview them. Where did you go to school? What do you do? What's your life like? And then we used a whole other set of more like doctory evaluations where we've got, the 𝐓𝐰𝐢𝐭𝐚𝐸 hand test, where we'll have, fine motor function being tested, range of motion. We can see what the range of motions are. What's our pinch strength, and what's our 2-point sensation. And so we had 2 sets, the patient reported set and we had the surgeon reported set, and we sort of looked at that analysis. And so the broad take-home conclusions from that study were that regardless of Apert type, okay, the only difference was in the range of motion of the digits. So whether you have a type 1 or a type 3, your sensation is going to be normal. You're going to have, your pinch, your grip, your ability to do things is going to be equivalent across Apert type. So it's a little harder. It may be a few more stages, but you're not going to end up any worse off than any other Apert patient on average in terms of function. Shockingly, sensation was normal across the board. 2-point sensation is the same as yours and mine, remarkably. And so they have very good sensation and they use their hands very, very, very well. Not all digits are going to work the same. So you may have a child who has the pinky, the pinky is their favorite, or the index is their favorite, or the middle finger is their favorite. You're not going to have equivalent function in all digits. And so some variation across digits, even within patients, is perfectly normal to have. We also found that while our functional measures were pretty different than normal, the self-reported quality of life and the self-reported function were pretty good. These were happy patients who were like, I'm psyched. This works for me, and I'm able to do what I need to do. It may look a little different. It may not be the way you use your hands, but they'll be able to use their hands to really conduct and do most of their day-to-day activities, and even more complex tasks as well. So all the little tweaks and things, whatever, do appear to be worth it in the long run. So just to summarize, the Apert patient is a unique entity. This is not something that, the average or even some pediatric hand surgeons encounter. We are very lucky to have been part of a craniofacial program here where we see Apert patients, if not every day, then every single week for sure. And so it's part and parcel of what we do, but it is a unique part of hand surgery. I think historically people have just said, we're going to focus on separating the digits. And I think that's an important thing, but it shouldn't be viewed as the only thing. We have a lot of different procedures now out there that are able to improve upon what we can get initially as the child grows and develops. Not everything is required by everyone, but there are relatively minimally invasive ways of addressing some pretty easy and important considerations in the hand as the child grows. So we tailor our treatment plans to every single patient. So that's a conversation. And we will continue that dialogue, sometimes remotely or through virtual visits throughout childhood. We really don't do amputations. Although when we talk to patients who'd had amputations at other centers, their long-term outcomes were really not that different from our own. And so if a child, for whatever reason, had to have an amputation or just didn't have that digit, I still think that the function would be very good, provided the other principles were addressed as well. Apert type does inversely correlate with range of motion, but not with other patient or surgeon reported outcomes. So overall function is going to be equivalent, despite the fact that the hand may be a little bit less mobile overall in a type 3 as compared to a type 1. And we should be optimistic. We expect good outcomes and good hand function. We have patients that play musical instruments, certainly use a cell phone, text, type, participate in sports. All those things are not just, heroic, they're expected. And so we, we'll be there with you to help address and try to give the best appearance and best function to your child's hands. So thank you very much for your attention. And I'd be happy at this point to answer questions from anyone and everyone.
Awesome. Yes. Thank you so much. This is fascinating. I've heard some of this before, but just to see the photos and the slides are so impressive. So thank you for sharing those.
My pleasure.
Anyone on Facebook, we do have some love coming in and some thank yous coming in. So
Great.
Anybody that has a question, I can see. If you are asking questions, you can go ahead and post those. Another thing, I do have, you answered some of them. So one of the big one is, will my child be able to play sports? And you answered that. So sports, instruments, I think you said multiple things.
Yeah. So Apert patients and Apert hands are no more fragile than any other child's hands. So you do not need to put your child in a glass case or prevent them from doing contact sports or whatever sport or musical instrument they want to do. Those desires, those abilities are absolutely innate. They don't live in our fingertips or our joints. They live in us. And we have many patients that do sports that are really, we have a mechanic, we have a patient who uses their hands for their living, and we have patients that certainly have played musical instruments as well. And so absolutely, that's something that, and we have one incredible skier who was on skis at like amazing skier. So We do not in any way, shape, or form inhibit or limit activities. Everything is on the table.
Awesome. Awesome. Thank you. One thing that I did have a question is you said that you can do up to 4 all hands and feet at once. What is the kind of the determining factor on doing 2 hands at once? And at what age did you say that you did that? Is that part of the determination?
So in general, that's going to be mom and dad's decision. We'll support whatever mom and dad decide. It's much easier with a under 1-year-old or maybe 1 to 2-year-old to take 4 extremities away. Once the child gets a little bit older, or if they're a real busybody, they may really be ornery for those 3 weeks that they're going to have the 4 casts on. So every child's a little different. Some kids are absolutely little Buddhas. They're perfectly happy to just sit there and be super, this is great. Others will want to have at least 2 limbs free. So we'll do hands, feet, or we'll do left and right. But that is a discussion we have with parents. That's not something we say it has to be this way or it has to be that way. And it's often, we'll learn by doing. If the patient did really well the first time with 4 extremities, we'll get away with 1. It's rare when the feet are going to be done in 2 no matter what. So you're never going to have more than 2 operations with 4 extremities. Never. The 3rd stage is just hands only because the feet are done at that point. So usually if the first one went well, we can get the second one in well too. But if the first one was like, yeah, they were really unhappy, then we would split it up and we wouldn't do all 4, but it's usually a conversation.
Okay, that makes sense. And then you mentioned earlier, and I have had this question before, feet are optional. Can you just talk a little bit more about that?
Yeah. So, I mean, I think that the Apert foot is a whole other talk and entity. It's not quite as clear. There's not like a type 1, type 2, type 3. The feet are their own thing. Functionally speaking, separating the toes is not really going to meaningfully augment foot function. Where the foot becomes an issue is like, is my arch fallen? Do I have like a hammer toe that's like really painful when I run? We've had a lot of patients as they start running, they're like, kills, I've got this callus here. We can, without separating the digits, address those bony issues. The separation is more just while you're there, and I want to make sure they can wear open-toed shoes and paint their toenails and feel comfortable that way. The hand, it really is a functional gain. And so there's good data with separation. With the feet, it doesn't add that much to the operation other than the prolonged casting. It's this otherwise the exact same steps we're going through, and we can be very efficient. It adds a little bit of time to the surgery, but not that much. And the recovery is the same.
Okay, makes sense. Thank you. Another question that comes up, what is the difference in a distractor and a pin? Can you talk about that?
It's a great question. So a pin is static. It doesn't move. We use it kind of like as if you were going to shish kebab, vegetables on a skewer. So it holds the pin holds the bones in alignment temporarily. The bones heal and you take the pin out. It's like an internal cast. The distractor does have pins in it, but it also has a little screw device that those pins move apart slowly, like a millimeter a day. The body tries to heal that. So the body's making bone as you're separating it. So it's harnessing the body's capacity to make bone that's going to allow new bone to form and make a longer digit. And again, that they do that for jaws, legs, mid faces, you name it. It's not unique to thumbs, but we've adapted it. We've got it's small, it's very light, and it works really well. But the distractor it moves. Both are temporary, meaning they both come off. The pin is removed, the distractor is removed, but they're used for different purposes.
Perfect explanation. Thank you.
Good.
Another question was, do you always use bone from the hand in the hand, or do you ever use bone from somewhere else?
So it's a great question. So I certainly grew up with If there's extra bone from like a toe or a hand, we were using the patient's own bone to generate bone. And if it was available, that was fine. But if you had to go into like a hip or an arm, it seemed like a big deal for a little bit of bone. And so there are bone substitutes that we've used very successfully off the shelf that are non-biological, meaning they're not going to have any infectious risk. It's not like a transplant or something like that, but are perfectly appropriate. And we use them all the time now. So if we're doing like this person, like that synostosis, that metacarpal synostosis we saw, and we take out a wedge of bone, we can use that bone at that operation. But if someone comes in and they're like, I just need to have my fingers just a little straightened, or we need to have that little phalangeal augmentation, we'll just use a little something off the shelf and it works perfectly well. So we typically don't use hip, which can be painful, or, wrist, just because we don't need another scar. We don't need to do it. It works well. Again, that Apert bone healing is spectacular and it will heal well.
That is fantastic. I learned something there for sure. I did not know that about Apert bone healing. So
yes.
Awesome. Okay, just a couple more, or three more. One was a question about nails. So you mentioned you can create nails, or how does that work? Are you taking nails?
So the nail is probably, I think from an aesthetic standpoint, something we've really, really focused on. And more often than not, it's that the nail plate that on the separated digit is actually too big, that you have this variation in nail size, or one nail is like 1.5 or twice as big as the other. We will often make a point of, when we do those initial separations, of really trying to get equal sized nail on each. And so trying to get the lateral folds right, getting the nail plate just right. We don't create a nail. The nail is there. The nail comes from this little fold of skin just at the base of the nail, and they're there. The nail is there in Apert syndrome. What we do is we try to align it so it's not just one isn't growing into the other, and we try to make sure that their direction and their width is equal or roughly equal across the digit, so we get sort of a more normal span. So we spend a lot of time initially, but then every time we go back, if there's a nail that's problematic, we can usually pretty simply address that to make that better through a relatively small procedure. But aesthetically, that's one of our big concerns, is trying to get the nail plate right.
Awesome. That is extremely interesting. I was very excited to hear you say that you had been doing these studies on long-term outcomes, because that has been a topic of conversation in the past with our adult members. And so if there's an adult who is considering wanting a hand revision, are adults good candidates, or is it better to do this before, you're 30, 40 years old? So
our adults are still great candidates for surgery. There's no doubt that obviously as life goes on, it's a little more complex, and we can't, we have to, you're not going to put an adult in 4 casts for, 3 weeks, but we do have adult patients that we treat as well, because we're, again, we're so familiar with it, where things like re-deepening the web, or trying to remove graft that is no longer needed, or straighten a digit, those are very, very doable, achievable things for, I would say, I think the oldest Apert patient we've operated was in their 30s here recently. And so, yeah, we certainly do that. So it's not like at age 18, it's just that at age 18, things really slow down, meaning the bones, your growth plates have closed. You got what you've got at that point, and then we'll try to work with that to try to get the most out of it.
That makes sense. Thank you for answering that.
No problem.
There are so many good things, and I will definitely have you close in a minute, but I just wanted everyone listening to just kind of remember, if you're just tuning in or if you're skipping around, make sure you go back and watch the slides. I think there was a lot of information on age and timing. And then a huge point that I like to pull out is the reason that team care is so important is because this is a conversation. I thought it was fantastic how you talked about operating in 2 surgeon teams. These are just fantastic points that it's a lot of information I don't want people to gloss over. So thank you for including that in the presentation. And then I guess my last question is just if people want more information or to reach out, where should they go to talk to you?
So it's terrific. I mean, the phone number would be 617-355-4964 is probably the best thing to do. The one thing I didn't mention, and I think also comes up, so we're pretty good. All of these operations are insurance covered or insurance based. So this is not like, even though I'm talking about aesthetics and cosmetic and we have the dreaded plastic surgeon title, this is not like that type of plastic surgery. So we do go through insurers. We do work with a variety of insurers. We work with literally almost every state in the US and a lot of international patients as well. And so it's not like, we do work with your insurance company or whatever vehicle you happen to have to try to help with what is obviously a fairly can be a very expensive undertaking. So we want to make sure that that's, that I put that out there. But yeah, the best number to call is just our office number. And then certainly feel free, if you want to email the, your association, they can certainly send me emails and we'll connect that way. Sam Hall as well. She's our craniofacial coordinator. She puts us in touch with people all the time. So please give out, Sam's email or our whatever email, and absolutely we'll do that.
Yes, thank you for that. Absolutely. People can reach out to CCA. We are always trying to help direct people to teams that they might want to talk to. So we're always happy to do that and help people find care. And a lot of times, like you said, I know that your center especially serves people all over the world, but there are lots of opportunities and lots of options. So if you are needing surgery, please contact CCA. We also offer financial assistance if you do have to travel. That's a big thing that we do, because like we talked about in this webinar, it's not necessarily a one-off surgery. You may be going back, but you want the best outcome. So it's definitely worth doing that. And yes, I'm glad you brought up the insurance part. This is definitely function. This is life altering for our kids.
Yes.
So it is not the plastic surgery, like you said.
Yes, exactly. All right, good. I wanted to make that clear. Yeah.
No, excellent point. So thank you again, Dr. Labow, for just this wonderful, fantastic opportunity. We will be posting this on YouTube in our library in a couple of weeks. So just look for it there. Right now, you can access it on Facebook, and we'll let everyone know when it comes out on YouTube in a YouTube premiere. So thank you so much for your time. This has just been fascinating and a fantastic resource for the craniofacial community.
Perfect. Well, thank you so much. Okay. It's been a pleasure.
Thank you. And happy Apert Syndrome Awareness Month, everyone.
Thank you so much. To you as well.
All right.
All right. Bye-bye.
Bye.